All right. Good afternoon, everyone. I think many folks have joined us at this point, so I will go ahead and get us started. Want to be mindful and respectful of your time. I'm very, very excited to have our speaker today, but wanted to welcome you to our webinar and go over a few things. So we'll get started. On behalf of the Northwest Mental Health Technology Transfer Center, we're very excited to have Pat Deegan here. My name is Christina Clayton. I'm one of the co-directors of the Northwest Mental Health Technology Transfer Center. We're grateful you could join us for this. And first, a little introduction about our center. The MHTTC network is a nationwide network that is supported by the Substance Abuse and Mental Health Services Administration, otherwise known as SAMHSA, with the purpose of disseminating and implementing evidence-based practices for mental health disorders into the mental health workforce. The Northwest MHTTC is based at the University of Washington in the Department of Psychiatry and Behavioral Sciences. We're responsible for providing training and technical assistance to Region 10, which includes Alaska, Idaho, Oregon, and Washington. And for anyone from Alaska, we know that's not the right size for your state, but we know you're part of our region and are grateful for that. Broadly, our goals at the Northwest MHTTC are to accelerate the adoption and implementation of evidence-based practices and other effective practices, to heighten the awareness, knowledge, and skills of the workforce, to foster alliances among culturally diverse practitioners, researchers, policymakers, family members, and consumers of mental health services, to ensure the availability of delivery of publicly available, free of charge training and technical assistance. How we do that is we work to achieve these goals by offering a website full of events, products, and resources from our center and many other centers. We offer live training events such as this one. We also archive most of our webinars so you can view those at your convenience. We have self-paced online courses through Healthy Knowledge. We have a newsletter, and we have research and practice briefs. So a lot of resource library material, lots of things on our website, and you can know all about the whole network by going through all the different links. We could not do this without the support of SAMHSA, and of course this content is not reflective of their official positions, but I want to get into a little bit about language. It is our intention to always be mindful of using language that promotes recovery and culturally appropriate terminology. This slide was actually built within the culturally responsive work group within the whole network, and we really encourage everyone to use and champion person-first language with emphasizes the individual, not a condition or diagnosis. This is a way to demonstrate respect for a person's dignity and worth. And we want to promote treatment environments and approaches that foster respect, dignity, and hope. Speaking of language, you clicked on a little box that said this is going to be recorded, so we ask you to be mindful of disclosing anything that's identifying about folks you are working with if you're in that kind of position. Next, we have a few logistics about communication during the session. First, we do have the chat box, but that is only visible to our support team. So while it's normally fun and exciting to chat amongst folks that are attending, it's just too large of a group to do that well. So if you have a technical issue, please share this in the chat box and we will try to assist. And because we are a large group, we are all muted by default. We will get to questions later. But if you do put a question in the chat instead of the Q&A, we can't move it for you, so we will probably ask you to put it in the Q&A. The Q&A, there are two different ways we'll do that. We will get to that after Pat goes through her initial portion, but one way you can do it is to type your question into the Q&A window. So you should see that at the bottom of your screen. You can also raise your hand, and if we have time and there's discussion time, we can try to unmute you so you can ask your question live. So we will be monitoring the Q&A box to facilitate as many questions as possible, and we may not get to all of them, but we'll do our best. We know we have allotted some time for this. Lastly, your feedback is very crucial to our work, so we appreciate your response to a short survey that's confidential, just takes a few minutes. It lets our funders know that we've done the work, and it also, more importantly, helps us provide better trainings and work for better things in the future. We are not able to provide certificates or CEUs for this webinar. I know that's disappointing to many. It's just not logistically possible for us at this point. However, the recording and other resources and slides, some are actually available and have been put in the chat, but we'll notify you when the recording is available. But now on to the good stuff. I'm very happy to introduce our speaker, Pat Deegan. Pat's mission is to help activate and empower mental health services users in their own recovery and to provide peer supporters and clinicians with the know-how to support people in their recovery journey. She is uniquely positioned to fulfill her vocation because she was diagnosed with schizophrenia as a teenager, then went on to get her doctorate in clinical psychology, and today leads a company run by and for people in recovery. She is a thought leader in the field of mental health recovery, has numerous peer-reviewed publications, held a number of academic appointments, and has carried a message of hope for recovery to audiences around this world. In addition to her work on the CommonGround Program, she consults with OnTrackNY and has helped the team at the Center for Practice Innovations develop an innovative model for engaging young people under the NIMH RAISE Study. And this model is now being adopted nationally. It's very exciting to have Pat here. She has so much power in her messages in the field, so I will quickly turn it over to Pat.
Hey everybody, I'm gonna take a moment and share my screen, and then we'll get started. Okie doke. Off we go. Okay, I can't see you, I can't hear you, but I do believe you are out there. And welcome, and thanks for taking the time. You know, these are wild times, and there's an awful lot going on. And the fact that you carved out a little bit of time here to learn more about the dignity of risk and the duty to care is a testament to your commitment and your passion for the work you do. And, you know, in these really trying times, I have seen some of the most courageous and dedicated and passionate work being done by providers of mental health services, including peer specialists, employment specialists, psychiatrists, clinicians, case managers, etc. You know, I'll never forget just seeing this nurse down in New York City working with young people who are experiencing early psychosis. And he, at the time, the clinics were all closed. And so he was getting on his bicycle, this was back in April, with a garbage bag with arms and a neck slit into it, and getting on his bike because he didn't want to take public transportation, and making his way out to people's homes to ensure that they got the medications that they wanted and were using as part of their recovery journey. And you know, it's not about the money. And I know you know that. If it was about the money, we would all be working someplace else. It's about the fact that we are here and we know that we are called to this work because somewhere, and I don't care how many letters you have after your name or whether or not you've actually been a user of psychiatric services, each and every one of us come to public sector mental health and are able to show up each and every day to do this work because somewhere in our lives, we have encountered challenges. We have been knocked down by life. Maybe it was an alcoholic family member. Maybe it was the loss of a child. I don't know how life knocked you down and gave us that feeling that maybe we couldn't get back up. Maybe we couldn't pass through this passage that at the time it was occurring maybe felt like it would overwhelm us or engulf us. But we did. We passed through the challenge, and we came out the other side transformed. We came out the other side different. And I think what makes us, those of us who've been through difficult passages in our lives, we come out the other side with a sense of hope. That's the greatest gift that we have when we're working with folks. We have a deep sense of hope that it is possible to make difficult passages in this life and to be transformed by those passages rather than destroyed by them. And that's what we come to work every day to give. And no amount of salary can compensate for that extraordinary gift that each and every one of you are bringing each and every day to the job. And I really want to thank you for that because it matters now more than ever. And based on that idea, today I'm here to bring you a framework for thinking about how to handle situations where people seem to be making choices that may steer their lives away from recovery. And that's where, as I like to say, the rubber meets the road. In my experience over these 30 years training and carrying a message of hope for recovery around the world, I find that most of us can get on board pretty readily with the fundamental principles of recovery. Hope, the importance of collaboration, the necessity of setting up goals for care and helping people achieve their personal goals. That the practice needs to be person-centered and holistic. I mean, there's usually no argument about these basic principles. These are values that most of us hold. However, when we get to the foundational recovery principle that includes self-determination, then there are some skid marks on the road. Then things can get a little bit tough. And that's where I see a lot of the time the principles of recovery-oriented practice beginning to break down. What happens when a person is making a, quote, bad choice? What should the team do if a person is making a choice that appears perhaps to be self-defeating? What if a person has made the same choice 5 different times, and each time the train went off the track, so to speak? You know, their lives began to derail again and back to the state hospital. Does recovery-oriented practice mean that we're supposed to, jump off the proverbial bridge when someone says they want to jump? Well, of course it doesn't. But how do we think about this, and how do we approach choice in a systematic and disciplined fashion? How do we support choices in those areas of ambiguity? Now, I wish I could give you a cookbook with specific situations and exactly what to do, but of course, that's not how mental health services work. Most of the work we do occurs in that land of ambiguity, right? Where nothing is quite exactly clear as to how to proceed. And so over these years, I have developed a very real world framework that I'm going to teach you today that will help guide you and your teams in working with people in these areas of ambiguity around choice and self-determination, especially when someone seems to be making a choice that may steer their life away from recovery. That's our topic for today. And this framework is part of my overall Common Ground program. This is a brief nudge to you to get over to my website, CommonGroundProgram.com. You can also reach it at patdeegan.com. This is an image of me in Israel in December before the pandemic hit. And I'm giving a lecture to a big audience over there. And it's my favorite meme slide of all times. It's the most essential thing where all of the work of recovery-oriented practice begins, and that is, I am a person, not an illness. It's the basis of everything we do. I am a person. We meet people in recovery-oriented practice. The very starting point of recovery-oriented practice is to meet the people we're working with on the common ground of our shared humanity, right? The common ground of our shared humanity. That's where all of the work begins. It's not us or them, right? It's not the people that we've come to you have the know-how to get fixed. That's not recovery-oriented practice. Instead, it's by discovering the fact that the people we work with are more like us than not that we can actually begin this important work. So the thing about risk, when we think about the common ground of our shared humanity, is that risk can make us feel vulnerable. When a person that we care about is making a choice that could be self-defeating or steer their life away from recovery, then in fact we can feel vulnerable, and we might want, with the best of intentions, to somehow prevent them precisely because we care. And yet, taking charge of a situation can also, as we're going to learn, have toxic effects as well. I want to just give you a brief story from my own recovery, because a lot of times the way we influence or try to manage a situation with risk because we feel vulnerable because we care about this person, it sometimes doesn't work that way at all. And an example from my own recovery is, I remember early on, it was one of my earliest hospitalizations after being diagnosed with schizophrenia. I was all of 17, 18 years old. And I remember, I think it was the second hospitalization because or the third, but anyway, I was completely focused. I think it was only in for 2.5 or 3 weeks. And it happened like in March, I think. And I was totally focused on getting out because I had started a course in English Composition 1 at the local community college, right? And so I was in the inpatient unit, and my goal, absolute focused goal, was I'm getting out of here on X Wednesday afternoon because I want to get to class in time for my evening class on a Wednesday evening. And I remember stepping outside the hospital. I did it, I made it. And when I stood outside the hospital, I felt like I was on top of Mount Everest. I'm sure my skin had that kind of very pasty look that you can have when you're on way too much haloperidol. And I probably had eyes at half-mast and was walking stiffly. But by gosh, I had my suitcase in my hand. I was gonna go back to my parents' house, and I was gonna get on that bus and get to class that night. And by gosh, I did it. And I remember I probably looked like hell warmed over sitting in that classroom, but it was my choice. You know, and my team were very often telling me, you know, avoid stress. Don't stress yourself in this way. But by gosh, I wanted to get to class. This was the first time in my life I had taken a college course in English Composition 1. It was important to me. It's what mattered to me. So I got to class, and there was a professor. I really liked him. I even remember his name. It was Al. And he said to me at the break, you know, during the break, he came up with a big smile on his face. And he said, you know, Pat, he said, you look just awful. He said, why don't you just go home and just take a pass for today and come on back, you know, next week. And it was as if somebody had like punctured my drive and my hope and my ambition, because it just flowed right out of me. And I do believe that Professor Al there really meant well. He thought he knew what was best for me. He thought that my choice to come to class, I mean, he didn't have any of the backstory, but my choice to come to class that particular night, he had no idea of its significance for me, and that he thought he was doing a good thing for me, making a choice for me, a strong suggestion to leave class and go home. And I did. I left class and I went home, and I just imploded. That was it. I just didn't speak. Just as far as I was concerned, it was over. And I came to a screeching halt, and I stayed that way for some time. You know, the good news was eventually I did get my energy back, and eventually Al worked with me so that I didn't go back to class anymore, because I was out of it that long, like March through the end of May, just deflated. But then I eventually did my homework over the summer and was able to get my first 3 credits at college. But that's what I mean about choice. We may think we're doing the right thing, but sometimes it's just not, it's just toxic. And so that's why it's so important. All right, let me start. Before I get into my framework, to say a few brief words about what I call the edge cases. Sometimes when I talk about risk and a risk framework and recovery and the importance of self-determination and choice, the first thing people want to say is, yes, that's fine for, quote, high-functioning people, Pat, but if someone has a diagnosis of psychosis that is not terribly well controlled, or some other form of serious, a diagnosis of some other form of serious mental illness, we can't say that these people can make choices. This is for, quote, high-functioning people, stable people, or the like. That's the first objection here. But I want to remind you of the CATIE trials, clinical antipsychotic trials. It was a large real-world study conducted in the 2000s. It looked at 1,158 research participants, all of whom were in the real world diagnosed with psychosis. This is a study that happened across metropolitan areas across the United States. And people in the study were tested for their decision capacity every single, 3 times over the course of the 18 months of the trial, right? The antipsychotic trials. And what we found, and it really did surprise pretty much everybody, was that 96% of 1,158 participants diagnosed with psychosis remained above the threshold for consent-related decision capacity over the 18 months of the study. That kind of blew everyone's mind, and that only 4% actually, when tested 3 times in the course of the 18 months, only 4% fell below the threshold for giving consent to participate in the study. So I think this was published in the research, and I think that one important note was that 25% of people in the study did have a period of worsening decision capacity, but they did not fall below threshold. And I think that, so we're talking about perhaps as many as 3/4 of people continue to exercise decision capacity irrespective of use or not use of medications during this important research study. And what that tells me is that based on these findings, I think it is fair to say that most individuals that we serve, even the folks diagnosed with psychotic disorders, do have decision capacity and can make informed decisions, especially when the information is carefully prepared, like it was in the Katie trial. And that with this finding, I think we need to be expecting that the majority of people we work with, or another way to say it is that decision incapacity will be the exception rather than the rule when it comes to working with people around being self-determining. That most of the people we work with can participate meaningfully in decision-making and self-determining and making choices around what's happening with their life and with their recovery. Nevertheless, it can still be challenging to work with folks when they seem to be making a self-defeating choice. The second edge case that comes up all the time on this topic, so we're just going to deal with it at the outset, is what about my license and what about my liability? I don't want to lose my license. These are important concerns, you know, and these are fair concerns too when it comes to the topic of risk. And in talking with attorneys who specialize in disability rights, what I find is that attorneys are united on the message that what matters is not so much the choice a person is making. What really matters is that the team be very skilled at documenting care. That it's the neglect scenario. It's somebody stated they were going to do such and such and we did nothing. Okay, that leaves our licenses and leaves us in liability. But if we can actively document the care that we've been providing, the conversations we've been having, the support we've been offering around choice and self-determination, it is possible to work and not to be fearful of losing our license, but documentation is key. So in order to introduce the framework, here we go. I'm going to start with a real world example. This is true. Segi is of course, de-identified 26-year-old woman with a diagnosis of schizoaffective disorder and a post-traumatic stress disorder. She's been working with the team for 6 months. Part of her work with the team has involved exploring her history of being sexually abused in childhood and her involvement in an abusive relationship with a boyfriend who took money from her. The boyfriend is currently out of the house, and Segi has been successful in starting to limit her contact with him. Additionally, she's very interested in getting a job, but has refused to meet with an employment specialist. She says she wants the satisfaction of finding work on her own and has been searching local want ads and online job boards, and she has found work this way in the past. So, during her last visit with her primary clinician on her team, Segi reported that she was very excited about having landed a job interview. She had it scheduled already, and the job was, according to Segi, quote, making phone calls, telemarketing. The interview was going to be in a town that was nearly 15 miles away, and when asked the name of the company, Segi said the man she spoke with on the phone really didn't mention the name of the company at all. The address where the interview would take place was in a residential neighborhood. Segi would like and was asking her case manager to give her a ride to the interview, drop her off, and then she would take the bus home. So her treatment team was understandably hesitant, and the bottom line is they were feeling conflicted about supporting Segi's request. They're concerned that she's being lured into an unsafe situation. And as we listen to her story, I think we can definitely feel ourselves kind of being torn in two directions. So on the one hand, we want to do recovery-oriented work and support Segi's choice and her self-direction. That's what recovery-oriented practice is all about. But on the other hand, we're concerned that she may be making an unwise choice. We want to protect Segi and keep her from possible harm. And truthfully, it can be very challenging for clinicians to decide and for teams to decide how to proceed. So my first rule in introducing the framework is to say that because the team feels conflicted, precisely because they care about Segi, right? Because the team feels conflicted about the self-determining choice Segi is making, the key to recovery-oriented practice is not letting our internal experience of feeling conflicted become an actual conflict between Segi and the team. Because once we are in conflict with her, we really have taken a big step backwards. Where we want to find ourselves in recovery-oriented practice is working side by side with people. And I'm visual, so instead of, this being how we're working with folks, right? We want to be side by side with people. And in order to do that, we can apply a more detailed risk framework. So imagine, if you will, a continuum with neglect on one side and overprotect on another side. It would look like this. And when discussing how to approach a situation like Segi's, clinicians often initially trend towards overprotective responses. Overprotective responses are the responses where the team tries to make the decision for Segi. And sometimes this can take the form of trying to bribe, I've seen it many times, trying to bribe or to coerce the individual into making the right choice. We care about the person, so try to get them to make the right choice. And here are a couple of common examples I've run into many times in my consultation work. One would be to offer her a special meal during the time when the event that we feel conflicted about might happen. In this case, offer her to bring her out for a special meal during the time when the interview is scheduled. Another one that's more coercive, but it's still about us trying to take control, is suggesting that perhaps, Segi, you may be endangering yourself. You may need to be hospitalized you may lack insight into the danger of this situation. Well, in my framework, this overprotective response then can swing to the neglect side, right? When all of our efforts toward overprotection have failed, we feel frustrated, we're trying to give her great advice, we're, trying to, quote, make the right choice. Very often then you see teams swing to the other side of the continuum. And this is particularly true if the team has seen the individual make a series of poor choices with bad results over time. I think it's very natural to get frustrated because what's driving the team's frustration in that situation is the fact, again, that we care about the person. And here's the kind of thing, and these should become red flags for team supervisors out there. When we hear these things, we need to focus on the team. Things like, we'll just have to let Segi hit bottom and suffer the natural consequences of her actions. That's the only way she's going to learn. We need to stop enabling her, right? Or another thing that we will very often hear when the team is swinging to the neglect side of the continuum is, well, Pat Deegan says one of the core principles of recovery is choice and self-determination. I guess we'll just have to let Segi make her own choice. And not just figuratively, but literally, teams very often will kind of do this thing where they like step back and hold their hands up, kind of like, she's going to have to hit bottom, suffer the natural consequence, or she's going to have to, learn her lesson after she hits bottom. And in that movement back, in that kind of holding up of hands and literally letting go, stepping back, what's happening is that the team is disengaging from the individual. Very, very common and understandable, right? Disengaging from the individual. And, quote, we let that person, we let them make their own choices. And of course, this is not recovery-oriented practice. This is not empowering Segi. This is, in fact, neglect. I'm going to just say it flat out. It's neglect. And in the common ground approach, what we do is strive to avoid these toxic extremes of neglect and overprotect. And there are two principles that help us to navigate these extremes, and they are the duty to care and the dignity of risk. So, the duty to care helps us avoid the extremes of neglect and overprotect. What it means is that staff have a responsibility to remain engaged with individuals no matter what choice they are making. There is no standing back and letting go, right? And putting our hands up, right? Stepping back. When it is the responsibility of the staff to remain engaged with the individuals that we serve, and that Segi needs the team now more than ever, as she faces this important choice about whether or not to go to that job interview. And stepping back and letting her, quote, suffer the natural consequences of her choice is neglectful. The duty to care means we remain engaged no matter what. Segi needs us now more than ever. The second principle that we apply simultaneous to the duty to care is the dignity of risk. This is the second principle. The principle of the dignity of risk comes from the disability rights movement. It evolved in response to what people with disabilities call the over-medicalization of our lives. Really, what it came to be within the context of the disability rights movement, the dignity of risk is a cry for self-governance and self-determination. I want to tell you a brief story about how I learned about the dignity of risk. There's a guy named Charlie Carr, and when I was 17, you know, I was diagnosed with schizophrenia and hospitalized. When Charlie was around the same age, he broke his spinal cord, and after being medically stabilized, was put into a long-term care facility. And in the 1970s, the expectation was that Charlie would live out his young life for the rest of his life in a long-term care facility. And in such a facility, the nurses, of course, and the staff grew very fond of charismatic, great sense of humor Charlie. And yet every aspect of his life was overseen by medical care providers who very often overrode his choices for his own good, according to the way Charlie tells the story. Well, eventually, Charlie was able to get connected with the disability rights movement and became part of a core group of people nationally who were able to lobby Medicaid for personal care attendant services. With that, Charlie was able to start thinking about going to Boston University, where he wanted to go to school, and actually living on campus, right? And so eventually he did make it out, but the nurses, you know, just warned him and warned him about, you know, as he put it, Charlie, don't get a shag rug. You don't want to get rug burns and have skin breakdown, you know, if you're quadriplegic. And so Charlie and his personal care attendant were able to secure on-campus housing, and Charlie's first appointment had the biggest, baggiest shag rug you could dream of. You know, Charlie's personal care attendant left service around 10 the first night. Charlie, you know, I don't know exactly how, but managed in his electric wheelchair to do a face plant way down into his fabulous shag rug, and spent the night on his face in the shag rug. And then Charlie's whole face, as he's telling this story, lights up, and he said it was the most wondrous night of his life. And what he meant by that was that he had exercised the dignity of risk. What he meant by that is he made a choice, and he made a lousy one. But by gosh, it was his choice, right? Long story short, Charlie went on to become the commissioner for the Massachusetts Rehabilitation Department here in Massachusetts. But he didn't know that at the time. He was just a college kid spending the night on the rug. Anyway, that's what the dignity of risk is all about. From the perspective of the dignity of risk, Segi's choice about attending the interview is an expression of self-governance. And therefore, overriding her choice is not benign. It is a form of toxic help. And let me explain what I mean by that. When we take risks and we try something new, we test our limits and learn about our capabilities. We test our limits, we learn about our capabilities. And if others try to protect us by not allowing us to take risks, they prevent us from learning about the full reaches of our human potential, our capabilities, and our capacities. So actually, overprotection, no matter how well-intentioned it is, stifles growth. And it shows fundamentally a lack of respect for that which makes us all human. That is the capacity to choose, to decide, to take risks, to grow, to learn, and to experience our human potential. And that is why overprotection, although well-intentioned, is in fact toxic help. It's toxic help because it is help that hurts in the long run, that undermines our sense of self. So, this dignity of risk really emphasizes the importance of choice and self-determination as fundamental affirmations of human dignity. I'm going to say that again, right? The dignity of risk emphasizes the importance of choice and self-determination as affirmations of human dignity. And when we support people in making their own choices, we affirm their dignity. And this, my friends, can be deeply, deeply healing for the folks we work with. So, to summarize then, I'm offering a 3-step framework here for you to consider incorporating into your practice. In the CommonGround approach, this 3-step framework is used to guide us when a person is making a choice that appears to be steering their lives away from recovery. So the first step is to ask, what would an overprotective response be? The second step is to ask, what would a neglectful response be? Right? And the third step is to apply the principles of the duty to care and the dignity of risk. It's not an either-or proposition. So teams that are starting out with this framework very often tend to say, well, I think we should apply the duty to care here. The idea is to apply both simultaneously, okay? So I've developed a worksheet which you can download after this presentation, and it's called Applying the Duty to Care and the Dignity of Risk, right? And this worksheet can, what's with worksheets? I make a lot of them. I think they provide they operationalize principles in recovery-oriented practice so that we can learn them over time. When you walk away from this webinar, you probably won't remember all of the framework. So I create worksheets so you can bring them to your teams and use them routinely, and then this framework will become second nature for you. So for instance, when I work with the OnTrack New York coordinated care specialty teams across the state, the teams working with these young people with early psychosis, they have internalized over the years this framework. And now we routinely talk about, this sounds like a situation where we really need to apply the dignity of risk and the duty to care. And it becomes a shared language for the team to think about a recovery-oriented practice in these difficult areas of self-determination when someone may be making kind of a lousy choice. So that's the value here. So first step, describe a situation in which an individual you're working with is facing an important decision or choice. Well, say he wants us to take her to an interview and drop her off, but she doesn't know the name of the business and the location is in a residential area. We're worried that she's being lured into an unsafe situation. So that's the situation that's got the team concerned and feeling conflicted. Then the worksheet instructs us what would the overprotective response to the situation be. Well, and we really encourage teams to be a little extreme here, because it helps to say, that really is ridiculous. Sending her back to a hospital, that's a little much. But by going to kind of the extreme, it helps us say, okay, this is where we need to avoid. We don't have total control, but we also don't want to go here. Another choice, take her to her favorite restaurant during the interview. No, tell her it's not a good choice. And then tell her we are going to look for a different kind of job opportunity for you. And then we ask ourselves, okay, what would the neglectful response to the situation be? And again, I want to encourage us to think in kind of you know, let your imaginations go. Drop her off at the interview and keep my fingers crossed. Well, yeah, that's neglectful. And oh yeah, we don't want to go there. Okay. It's her life, her choice. We'll let her make her own choice. No, that's neglectful. And then this whole stuff about suffering natural consequences. You know, very often people that we leave to suffer natural consequences end up returning to state hospitals or taking their lives, or just terrible, terrible outcomes. And so we don't want to go there. So what if we apply both principles now, the dignity to care, the duty to care and the dignity of risk, where do we come in? And we should think about that, you know, guiding us somehow down a more central, balanced path. And one thing is we could review information about employment scams with SEGI. Because this may very well, with this interviewer saying telemarketing from a residential job center, I don't know. How about helping SEGI develop a safety plan for that particular encounter? Ask her employer to conduct the interview in a public space. So that's how you use the worksheet. It's very concrete. It'll help you operationalize the framework that we've just discussed. So let's try another. So this is Darnell, another real world scenario. Darnell is 22 years old, is diagnosed with schizophrenia and living in supported apartment program. Darnell's been on an antipsychotic medications for about 6 months. And he has a body mass index in the obese range. And 6 months ago, he was diagnosed with type 2 diabetes. He was started on metformin. He also met with a diabetes educator who provided information about diabetes and how lifestyle changes can help reduce the risks of this disease. Darnell's team reports that despite numerous attempts to educate him about diabetes and the dangers of consuming sugar and the option of drinking non-sugared beverages, he continues to drink sugared cola and tends to eat unhealthy food options given his diet type 2. So team members are feeling, you know, very concerned. And I remember the nurse on the team telling me, you know, I just refuse to be a part of Darnell's descent into advanced diabetes, okay? Clearly that nurse cared very much about Darnell's health. So applying, you know, avoiding the extremes of neglect and overprotect. What might be an overprotective response? Move them to a supervised group home from a supported apartment program would be one just way extreme. Another might be hospitalize them for danger to self or other. I mean, it's extreme, but that's okay. And it's a reminder, I don't want to go into overprotect as our team is not going there. Neglect, it's his choice. You know, he's gonna, you know, maybe it's just gonna have to hit bottom. A lot of people with diabetes have to before they can, you know, follow the program. So maybe it's neglect, or maybe we just keep working on mental health issues and say, you know, we're not a physical health care provider. That's up to his primary care doctor to deal with him about that. We want to avoid neglect for sure. Instead, we want to apply simultaneously the duty to care and the dignity of risk. And here are some possible ideas, and I'll bet you anything you guys can think of more. I'm sure most of you have encountered similar situations. Certainly we could provide information on diabetes. When we're providing information to people around supporting decision-making, what we want to be careful to do is we don't want to bomb people with too much information because that paralyzes people. Information that's really helpful information is what's called just-in-time information, what I need to know right now, depending on where I am at. So just-in-time information. What about exploring something other than olanzapine, which of course has a very high risk for metabolic syndrome and type 2. That's probably a really great option. What about using motivational interviewing? And that could help us understand where, if anywhere, you know, is he in pre-contemplation? We shouldn't be bombing him with action moves if he's not in an action stage for change. You might have to start with the pre-motivational worker. Okay. What about peer support? And in this sense, there probably are plenty of peers who, you know, are getting services in the mental health system, but who also have type 2. Or he could get peer support through diabetes support groups as well. Explore healthy alternatives, maybe get lucky with them and strike on something that helps. Certainly exploring the pros and cons. I'm going to talk more about that right now. The way to explore pros and cons is to really get involved with another extremely valuable worksheet, which I call the Decisional Balance Worksheet. You have a copy of my Decisional Balance Worksheet for you to begin implementing when you're done with this webinar. So here's an example of a Decisional Balance worksheet. So this is Angela. And she's announcing to the team, "Hey, I'm quitting the meds. I'm done. I'm quitting the meds." And that would be you know, if we allow our feeling of being conflicted about that to get between us, we could start going head to head. And instead, we want to get side by side with her. And this is the tool to do it with. This Decisional Balance Worksheet is awesome. And it will help you get side by side with people in recovery-oriented practice. And so basically, it asks us to describe the decision that she's facing. I think, let me just step back for a minute and say, you know, I think, you know, Angela, you know, here announces, "I'm quitting the meds." And I think the response that really works would be for me as a peer specialist, or me as a psychiatrist, or me as a primary clinician. I might say, wow, that's a really big decision. Tell me how you made that decision. Tell me about that. I'm interested in learning more about this decision, because now what I'm doing is I'm framing what's going on as decision making. And once we're doing decision making, I can help support the deliberation that goes into making decisions. And so I just want to briefly tell you how to use the Decisional Balance Worksheet. The steps are all laid out. But essentially, we would sit down with Angela. You never give someone a worksheet and say, "Now go do it." What we do is we suggest that Angela and I have a conversation about this important decision that she's making. I don't even have to show her the worksheet to start with. And I repeat what's the decision that she's making about whether to stop her medications. And then we list the options. So option 1, option 2, maybe option 3. And then we list the pros and the cons. But importantly, we don't stop there. A lot of people stop there, and it's not far enough. What the research tells us, in order to support deliberation and decision-making effectively, what we need to do is, once we've listed with Angela telling us the pros or the reasons to choose the option of staying on meds, going off meds, switching meds, is this. And the reasons to avoid this option are this, and we work with her to list those. And the most important part is, then we say, okay, on a scale of 1 to 5, with 5 stars being your most important, the most important thing to you, and 1 being meh, not so important to me, not important to me. Give each of these pros and each of these cons a star rating, 5, 4, 3, 2, 1, right? Because then what's happening is she's conveying her values to us, right? Then she's conveying her values, meaning that if option 1 is, I could go off meds, and she gives that up, yes, I think that would be great. But then we learn what's even more important is that she can keep her job. So that might add some weight to the option, to a different option. We learn so much by having people clarify their values, why this is important to me, why this is not so important to me in regards to my option. So anyways, it's a great worksheet, and I encourage you to use it routinely, and I think you'll be pleased at where it takes you. So I know it's time, and so I'll stop sharing my screen, and we'll move into Q&A. Christina?
Great. Yes. Thank you, Pat. We do have some questions, so hope you're ready. First one from Julianne. What do you recommend in high-risk situations involving violence? Recently, a consumer we are working with significantly injured a peer and started stalking a staff member. The team does not want to involve police due to the consumer being a Black man and the risk of being harmed by police. The team would like to stop providing services as a result. If that were to happen, the client would not have access to outpatient services. How do you navigate balancing both ends of the spectrum of neglect and overprotection in situations like this?
Yeah, so I think violence is an extreme edge case. And I intentionally, purposefully presented scenarios that are more common and don't press our danger due to there being a threat of violence, or in this case, the actuality of violence. I would, I don't know the extent or severity of the violence, but violence is violence is violence, and it's not cool. And I think that the team needs to address it. I think the team, it's difficult to just say in general, I don't see that this person has exercised self-determination in becoming violent. And I think, danger to others is a pretty well-defined criteria, although like anything in risk frameworks, it's not a cookbook. So, I think the worst thing that could happen would be for the team to discharge him from care. I just think that is what we want to avoid, and it is not a solution. Too often it makes things much worse. I would avoid that extreme, and I would also, almost go as far as to say it's neglect. I just don't believe in discharging people who are hurting from care, even though it might be expedient. And I would absolutely insist on safety planning. And this is not a workshop or a webinar about safety planning, but I think safety planning is critical. I think one of the other things I'll mention in terms of recovery-oriented care is, I remember being on inpatient units sometimes when there would be violence, and the person would be, quote, removed from the community, removed from the milieu, usually spent time in restraints, eventually returned. And there was never any reentry prep, never any working with the community of peers who happened to be inpatient at that time about processing the event, about safety planning for ourselves, but also with the individual who had made the transgression to think about making amends. You did something really crappy. You hit somebody. You dumped a table over on them. That's not all right. This is where an amend is required. This is what we do in terms of a social contract with people. And we're really not good at supporting people in making amends. Anybody who's interested could go to my blog on my website. I got a really interesting blog post up about making amends. And I encourage you to have a look, because I think I take a stand on that issue that a lot of people find surprising, given what I'm saying here. But I do think it is important in mental health. We know about it in 12-step recovery programs, right? The importance of the fourth step about making amends. but I believe in helping the people we're working with who have transgressed either through violence or through some other threat, who've harmed relationships through an act, to help repair, to help make reparations for that act. And so I would be looking perhaps at a treatment plan focused on that if he was willing and interested, and I think peer support around that can be helpful. I'll offer one more tip, and then we can go on. But I hope this is being helpful. I can't see your face, so I don't know. But so it's the idea that sometimes we do things, and I mean all of us, not just people receiving services, but all of us do things that we're not proud of, and that we wish we hadn't done, or that we feel badly about, and we want to make amends. But I think sometimes we don't, and there's a lot of reasons why. But what I notice when working with my peers who have been violent at some point, myself included, I've had that experience, is that I may believe that this person was out to get me, and they've been on my case, and I had it, and I just wanted to, and I snapped. That's what I believe happened. That's my belief. But I also have values as a human being. And my values are that I'm a kind person. And my values are that I care about people. And my values are that I believe in nonviolence, whatever, and we help people deepen, not confront their beliefs, but rather help them deepen their sense of what they value, articulate the value, and then you can compare the belief, he was out to get me and he deserved a pop in the face, or whatever it was that, the person is saying caused me to do this, and then weigh it with the things in my life that matter for me. And I've seen that really help to open people's heart when they've been aggressive and approach the party that has been harmed with the purpose of making an amend. And that's a beautiful thing. In other words, we can take this and turn it into healing with maybe. There's always a chance we're not going to get anywhere with it, but maybe. So it's tough. It is. It's hard.
Thank you. Well, we have some more questions rolling in, so I'll get to the next one. Thank you for that. A client says she is interested in recovery from methamphetamines at times, but refuses to go forward with this. She sees that she hasn't been able to hold a job and has had difficulty getting a job with no real work history. As an employment specialist, I've had a hard time advocating for her with employers, which I typically do as I network and build partnerships in the community. My tendency under these circumstances is to stay behind the scenes and just give the client information to get info on jobs on their own. Holding out on the personal networking with employers when addiction prevents follow-through with the employment specialist and when work hasn't been possible while using drugs for over 20 years seems reasonable but questionable. So I think that ambivalence about how do I help this person? Do I go to the links that I normally go? That's sort of what I'm reading into this question. So it's a tough one. So
it is, and I also think another factor here is that it's not like I think employment specialists really are trained in fidelity practice and work hard to cultivate a trusted network of employers, and to steer someone toward that trusted network of employers who has a severe addiction. We can feel a little nervous about burning the turf there, right? A little nervous about that. So I get it. At the same time, I'm thinking about Bob Drake and Debbie Becker, and I'm thinking about over 21 worldwide randomized controlled trials that say when somebody says they want to work, let's support them in doing that. And I'm thinking about 3 long-term studies done on IDDT treatment with people with addictions in both urban and rural settings, including New Hampshire, and the finding that over time, many people do in fact make tremendous gains, both in employment, life satisfaction, family, and all the other stuff that matters in life. So there's always hope. I would encourage you to, I guess, I think it's about finding the niche, that right place in the right environment where that minimizes the areas where she's struggling and builds on the areas where she has strengths. And I'd say stick with IPS because there are 21 randomized controlled trials that know better than me that in fact it works if you work it. And it's going to take courage on your part. So yeah, I just say that's what we're there for. That's what we get paid to do, is care, 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 engage, engage, engage.
Yeah, thank you. And I think it reminds me of interviewing staff back in my old job and realizing that work might be the thing that's motivating someone to maybe take a look at their substance use, whereas we might think it's something else that's motivating them to quit or cut down. But work can be a very powerful motivator, but it's taking that risk, as you said. So the next question is, when someone in an inpatient setting says they want to stop all medications and they decline support in titrating off their medications, and sudden withdrawal carries some risk of severe health concerns, how does one balance neglect versus overprotect?
So in that situation where there is an imminent danger that abrupt withdrawal most probably will lead to ill health, it's time for shared decision making. You know what I'm saying? Particularly in an inpatient setting. I mean, I think the psychoeducation can go so far, helping the person understand what's at risk, helping the person, offering that critical decision support, looking at the pros and cons, working the decisional balance worksheet, being side by side with the person, not getting into that head-to-head conflict. What would be the options? Are the options that we are going to titrate off? Is the option going to be that we're going to abruptly discontinue? Are those the only 2 options? Is there a third option? If so, what is it? And then looking at the pros and cons of each. And then, for instance, I'm sure that one option would lead perhaps to an earlier discharge than another option might. How do you weight that value on the 5-star scale, right? Is that a value or not a value? So I do get that it can be frustrating, but I also know that this is about human dignity and affirming human dignity and the dignity of risk and of choice, and that getting side by side with this person is where we want to be. And I would say the decisional balance worksheet is your best friend in this particular scenario.
Yeah. Well, and as you said earlier, sometimes people are trying to exert control wherever they can. And this is sometimes how that comes out. And maybe if you do that motivational interviewing, talk to them more, find out what's behind that choice that they're exerting, you might learn more. That's what I'm hearing you say earlier too. Thank you.
I also would like the person who asked that question to encourage you to come to the final 2 webinars in this series, which is about the journey to use meds optimally to support recovery, because I'll blow your mind with this content. It's all my newest stuff, and it's amazing stuff about how to really support people who are having those kinds of experiences.
Yeah, we'll get that link so people can see where those are and register in the chat here in just a minute. All right, we have a few more. Have you ever met a client who has been asked by a psychiatrist if he or she or they have thought about suicide today, and then when they said no, the doctor says that they can no longer help him or her or they, and then walks them out of the office?
Can you read it to me slowly?
Sure, yeah, so I'm sort of reading it verbatim. Have you ever met a client who has been asked by a psychiatrist if they have thought about suicide today? When the client said no, the doctor tells the person they cannot help them and then walks them out of the office. So I don't know more about the situation, but wondering if there's some sort of situation where they only see the doctor if they're in true crisis, acute suicidal ideation or something. So I'm not sure if you have thoughts on that.
Well, yeah, I mean, I think that, this happens sometimes. I build, one of the things I do is build software that people use with peer specialists prior to seeing psychiatric care providers, right, at the clinic. It's called CommonGround software. And people answer a series of questions, one of which includes, since my last appointment, I've thought about hurting myself. I figured exactly how it's, and then the other one's about hurting others, thoughts of hurting others. And that answer set goes, is condensed into a health report and proceeds the person into the psychiatric care provider appointment. And it sometimes, I'm not saying all the time, but sometimes when a person gets face to face with the psychiatric care provider, they deny, I must have hit the wrong button, okay? That people can feel sometimes like really intimidated by that. And by trying to answer truthfully such a heavy, kind of profound question. And so my sense is in this scenario that you're talking about in this question, somehow the person had indicated some sort of, given some kind of indicator that perhaps they had some sort of serious suicidal intent for suicide or for hurting themselves or something. And in that situation, I just think the psychiatric care provider, I think, was having a bad day because you don't leave people in that place. And you don't need my help because, like, clearly sometimes people say things and then deny it because they're afraid of anything from getting hospitalized to actually doing it, to hearing it out loud, having another person know. There's a myriad of reasons. And so I think just lightening up a bit and trying to, again, instead of being confrontational, get into that side-by-side place. And, suicide and suicide risk, and that's just the most, talk about vulnerable and fragile place for us clinicians and peers to be. Ooh, I mean, and I think what happens is that teams constrict, and our risk tolerance rapidly evaporates in the face of, really significant risk like harm self, harm other, in the kind of that absolute sense. And one of the things and some of the feedback I get from the New York teams is that as they grow more comfortable, as our relationship builds with people, as we get to know people better, our risk tolerance increases because we know the human being. And that's important, that the more our systems trend toward, what do you call it, where, contract doctors that change all the time and contract clinicians that, and each time you go to the healthy checkup thing, there's a new person seeing you. I think the risk tolerance is almost not there. It's not a good trend in our healthcare system.
Thank you. What would you advise to a team that feels the person they're working with is part of that small percentage of people that actually has diminished capacity to make safe decisions? And I'm just going to add my 2 cents to this because this is kind of work I used to do when folks are not on medication that would really be helpful or using substances, as people were sharing. So maybe any of those factors might be the reason that this capacity is diminished. But yeah, how would you respond to that question?
So if a person falls below the threshold of decision capacity, the law in our states varies, but is pretty clear that we have options regarding medical guardianship, or and I think that that's the time we exercise it. If in fact there is not decision capacity, that's what those laws are there for. Other than that, I think we assume decision capacity, and if it's fluctuating, if decision capacity is fluctuating over time, so that you see these dips in decision capacity, but folks don't actually go below threshold, like in the Katie trial, right? That can become really challenging then. So then I think what we need to do is focus on the quality of information that we are giving to people, and make sure that it's a finely tuned information that informs decision making in language and terms that people can understand. And I think that supported decision making in those moments can be really, really important. And also, I like to say, waiting for those islands of clarity. Sometimes people who are struggling, for instance, with psychosis, and maybe have wavering decision capacity, do experience these periods, however short they may be, where suddenly you feel like we're able to connect and have kind of a give and take conversation where information is being processed, and we know that because we're asking the person to teach us back so they can demonstrate an understanding of what we're saying. I think that can be a really good way to proceed. Look for those islands of clarity. There's also, I think there can be also, this could be important too, I think, is supported deliberation, where we invite the individual who has wavering decision capacity to invite a loved one, a friend, family, a pastor at the church, to come to consult with us, and to have what's called distributed decision making. So sometimes a loved one or family member can support a particular line of decision making and support that individual until they get back to full decision capacity. This is a real part of shared decision making as well.
Thank you. Another question. I work for a community mental health agency in Chicago, and we've had to severely limit our physical contact with our clients, which has been really hard to meet them where they are and work physically alongside them, as many people have been facing for sure. It's been tough to support them in decision-making processes when so much has changed in our support. Do you feel there are any changes or things to consider when working with clients in a virtual way? What a great question. Thank you, Hallie.
Well, yeah, I mean, thank you, Howie. I mean, it's a great point, a great question. So, I see it a lot. I think we're dealing with any number of factors, as I'm sure you know, which is there's not any uniform access to the internet. Most people have smartphones, not everybody. Given that, some people don't have the financial means to support extra minutes for healthcare visits. And I think that teams in general, from what I can see, are really good at helping people access through insurance, etc., mobile devices, get minutes paid for. States have varying programs. I don't know what the case in Illinois or in the city of Chicago are like. So that's sort of the pragmatic thing that we want to make sure. Another thing is, I think, enlisting the support of family members or anyone that the individual is living with consent to support the meeting. I can just tell you that all the different things that I've seen, it's pretty extraordinary, the lengths a lot of teams are going to connect with people. Peer specialists, I think, are particularly good. at hooking up with folks, you know, even if it's just for, you know, a half hour and people are playing some video games together. People are, you know, one peer specialist is running a philosophy group that's hugely popular with one of the FEP teams. So I think that peer support can be kind of non-threatening and engaging for people. In New York, depending on where in New York, people are bringing a lawn chair and going out and meeting in the driveway, socially distancing with people, and having contact with masks on and doing it that way. So yeah, I don't have any great wisdom to share on that, other than be creative and talk to colleagues and find out what works.
Great, thanks. We have one more question that I wanted to find from the chat. And it was, how do you prepare teams for this recovery-oriented practice? And just knowing all the push and pull from those two extremes that you described earlier is, I think, what I saw over the decades that I did that kind of direct work. And people want to stay hopeful, and then they get frustrated, or they get worried, or they're scared for people, and that comes out in, well, then let's tighten the reins, and yet that doesn't really help either, right? And so how do you prepare teams to really embrace and be prepared for the ups and downs of this kind of practice, the challenges that it faces them?
Yeah. So I've done a lot of training with teams in state hospital settings. That's what popped into my mind of these trainings I've done with state hospital staff. And I always start by having their teams talk to me about when they were young and dumb and broke. So what did you do that your mother told you not to do? I want to know, you know, and get them sharing some stories, right? Like I remember this one clinician in a state hospital in Connecticut, and he says, well, as a teenager, he got to go on a ski trip with his school, the high school, and his mother told him not to break a leg and told him not to go to the top of the mountain. And the first thing he did was go straight to the top of the mountain and came flying down the mountain and broke his leg. And, you know, getting to kind of normalize this. You know, one of the things I like to talk about a little bit with this stuff is, you know, some of us, I'm no big fan of, you know, the old movie actress Elizabeth Taylor, but my understanding is she's been married, or had been married an extraordinary number of times, right? Something like 6 or something, a lot of times. She didn't have great insight into the fact that she wasn't very good at marriage. And one of the things I talk to teams about is, so if she had a treatment team around her, right, an ACT team around her, or you know, a residential program around her, you know, we would have told her after the first marriage, maybe no, second marriage, 6. In other words, people without a diagnosis get to make pretty uninsightful choices more than once in their lives. Why would we kind of got to begin to normalize some of the lousy choices that people are making in mental health systems as well. And I think it can really help teams to share their own kind of young, dumb, and broke stories of what your mother told you not to, but you did anyway. So that's a good way to lighten it up.
Yeah.
The common ground of our shared humanity.
Very, very helpful. Okay, well, any parting thoughts, Pat, before I do our little exit slides?
Yeah, you guys ask great questions. And again, I'll just reiterate, I want to thank you for all you do. I know it's not about the paycheck, it's because you care. And that's a beautiful gift you bring to the folks you work with. And it's the most important thing.
Yeah, great. Well, thank you so much.